I'm Lisa Richardson. I'm the Division Director of Cancer Prevention and Control at CDC. Well, currently the number of cases per year diagnosed, or about number of women, diagnosed each year is around 220,000. Still about 40,000 women are dying every year of breast cancer. Breast cancer trends have been improving with decreasing incidence rates as well as mortality rates. But given the aging of the population, the number of cases of breast cancer have increased recently. The racial and ethnic differences in incidence, for instance, Black women having a lower incidence of breast cancer is actually converging more to the overall rate of breast cancer. So that's also a puzzle as well. Lots of places for people to get in and look at these changes that are coming. Well, the one risk factor that women don't fully understand, or maybe the public in general, is that aging is the number one risk factor for breast cancer. So as you get older, your risk of cancer increases regardless of your family history, which is why we recommend mammography over a certain age, usually starting at 50. Well, some of the things that women can, behavioral factors that women can modify to lower their risk are to drink less alcohol, participate in physical activity, and maintain a normal weight. I believe breast cancer risk is increased by alcohol by about 1.2 odds ratio or so. And it's felt that it increases the amount of estrogen that circulates in the body. Genetic risk factors we think accounts for about 5%, a little bit more of breast cancer in the community. The number one breast cancer genes that we know about are BRCA1 and 2. These are the high-risk genes that we look for most commonly among women with a strong family history of breast cancer. There are several things that women can do to lower the risk of breast cancer, especially if they're at high risk. These include medications such as tamoxifen, which is a breast cancer therapy that is now being used for prevention. And some of the other medications like serotonin. Another maneuver that women can do, or procedure they can do, is to have a mastectomy, which lowers their risk at about 70 to 90%. A third of the risk can be lowered by using tamoxifen. Our challenge has been getting women to use the medication because it has a number of side effects, including stroke, high blood pressure, and blood clots, and not to mention uterine cancer, which is another type of cancer caused by the medicine. So it's a hard sell to women to do that. Screening tests are usually used in asymptomatic people, hence screening. And they work best in populations where the prevalence of disease is higher. Hence, that's why we recommend screening in older women, because that's where breast cancer is more common. There really is no cutoff. It seems a little arbitrary when women are reading the literature, or even physicians. It can be confusing about the age groups that we use. 50 seems to be a cutoff, but it's one of those things where it's your risk, your personal risk, your family history, and all the factors that have to be taken into account. Mammography is the main test that we use. There are newer methods for doing mammography, such as 3D mammography rather than film. I would be surprised if you could get a film mammography in this country currently. Some of the newer methods of mammography are 3D. Some hospitals are offering that, or mammography facilities, but those aren't currently covered by insurance because they're still not widely available. Well, the main benefit of mammographic screening is that cancers can be found at an earlier stage and treated. Therefore, we hope leading to a longer life for women after that, breast cancer free, obviously. The downside of that as well is that we find cancers that may not be a problem during women's life, and this is known as overdiagnosis. And this can lead to a lot of medical care that isn't necessarily needed to prolong women's life. It's predicted or modeled that about 15 to 35% of cancers are overdiagnosed in this country. Studies and modeling studies done by NCI and more recently by meta-analyses show that the decrease in mortality from screening is about 15%, which is about half of the overall decrease that we've noted over time in breast cancer mortality. All groups agree that women in their 50s and older should be screened every 1 to 2 years. The U.S. Preventive Services Task Force recommends 50 to 74 every 2 years. The difference in the USPSTF recommendations are that women between the ages of 40 to 49 should consider their personal risk and speak with their physician about their personal risk about when to start screening. Well, mammogram trends in the U.S. From about the early 80s to 2000 were all up, and that's when we had the peak of screening in the U.S. at about 77 to 80%, somewhere in that range. Since that time, the screening rates have decreased to the last number I saw was about 72 to 73% nationwide. I think one of our biggest for mammography screening or breast cancer screening in general is that one of the really tough things is what we talked about before about the confusion around messages. Who should be screened, who shouldn't be screened, when to start, when to stop. Some of those issues, we need a better communication research to figure out how to talk to women about these things. My experience, about 1 in 100 women will have an abnormal or an abnormality that will require, additional follow-up. And among those, most of those abnormalities do not end up being cancer. So it's one of the moderating messages that we have to give to women. Most mammogram abnormalities are not cancer, and that the workup has to occur to determine that. So for the highest, the two highest levels, suspicious for abnormality, suspicious for cancer, and highly suspicious of malignancy, women would be referred to a surgeon and evaluated, or the biopsy may be done by the radiologist, which may be more likely these days as they're found on mammography. And then the diagnostic workup would go that way to get a biopsy and determine that. For other abnormalities, such as a BIRADS3, which is, routine follow-up is suggested, another mammogram or some type of, other test might be done to sort of characterize that lesion, including ultrasound. The National Breast and Cervical Cancer Early Detection Program was started in 1991, 1992, after some language or a law was passed by Congress to start a screening program for uninsured women in the states. I think this program started with about 6 programs, 6 state programs. Now it's nationwide with all 50 states, some tribes and territories funded to do cervical and breast cancer screening. To date, I think we've screened about 4 million women, still doing about 300 to 400,000 women per year. And these are women who would otherwise not have had access to screening because they're uninsured or underinsured. The breast and cervical cancer screening program is morphing into more of trying to do more of the wraparound services of screening, follow-up, case management, making sure women, get to the places they need, and not just screening. So some of our requirements in the program were very prescriptive from Congress that we would spend 60% of all of our money on service delivery, and that requirement has been removed or eliminated. So we're looking more at the patient navigation and population level outreach to women, not just providing screening services. So we're, in the process of making that shift right now. Most of it, I think, is kind of laid out for us. That we're, an aging country, and we're going to have more and more, cancers diagnosed, and the system, I think, is going to be under some stress, and try to figure out, ways to deal with that and how to help women do better as they move along. The other big issue is survivorship. Breast cancer, 5-year survival is 90% overall, and there are going to be a whole lot more women surviving breast cancer with those issues that we need to deal with as well. From a public health standpoint, the one area in particular that we've been working on is we've been thinking about is how to develop a population-based surveillance system for screening where you could actually get real-time information. The more we can do of that, of the electronic health records, talking to one another, it'll just make those types of things easier as we move along. Because as we currently do our business, we're always 2 to 3 years behind in the data, 2 to 3 years behind monitoring implementation, and this is all about quality of care. And I think public health is moving more and more into that realm as well.